Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 488 of our pharmacotherapy series, which majors in ischemic and hemorrhagic stroke. We will continue discussing the case of patient PCP in parts 485,486 and 487 of this pharmacotherapy series. My next question to you reads: what antiplatelet or anticoagulation therapy would be recommended for secondary stroke prevention for PCP? We will begin with antiplatelet therapy for secondary prevention. Because platelets play a key role in the formation of atheromatous clots, various antiplatelet drugs, such as aspirin, combination aspirin, dipyridamole, ticlopidine, clopidogrel, and C-lostazole, have been studied for secondary prevention. C-lostazole is the only agent not approved by the Food and Drug Administration, FDA, for secondary prevention of ischemic strokes and transient ischemic attacks arising from non-cardioembolic origin. These agents generally work by either preventing the formation of thromboxane A2 or increasing the concentration of prostacyclin. These actions seek to re-establish the proper balance between these two substances, thus preventing the adhesion and aggregation of platelets. Around 22% relative risk reduction of stroke, myocardial infarction, or death is noted with these agents compared to placebo in patients with prior transient ischemic attack or stroke. Based on the current guidelines for non-cardioembolic ischemic stroke and transient ischemic attacks secondary prevention, aspirin, clopidogrel, or combination aspirin, dipyridamole extended release are considered first-line therapy. We will now briefly look at aspirin. The effectiveness of aspirin for secondary prevention of non-cardioembolic ischemic stroke and transient ischemic attack is supported by evidence of high quality. At least 15 randomized trials, with 7 being placebo-controlled, have studied aspirin alone or in combination with other antiplatelet drugs in the prevention of vascular events. Patients were enrolled in these studies for as long as 5 years after experiencing a vascular event, i.e., transient ischemic attack, stroke, unstable angina, or myocardial infarction. Follow-up periods lasted from 1 to 6 years. The incidence of ischemic stroke or transient ischemic attack ranged from 7% to 23%. The aspirin-treated patients experienced an average 22% decrease in relative risk of a stroke compared with those receiving placebo. In 10 trials that considered only transient ischemic attack or stroke patients, there was a 24% relative risk reduction in the incidence of non-fatal stroke associated with the use of aspirin. The risk reduction rate is equal for men and women. Dosages of aspirin used in clinical trials have ranged from 30 to 1,500 mg per day. In a meta-analysis of placebo-controlled studies comparing 900 to 1,500 mg per day of aspirin, with similar studies of 300 to 325 mg per day, there was a 23% reduction in the risk of cerebrovascular events for patients receiving 900 to 1,500 mg per day and a 24% reduction in risk for patients receiving 300 to 325 mg per day. A prospective comparison of aspirin doses in 3,131 patients showed a 14.7% frequency of non-fatal stroke or non-fatal myocardial infarction in patients receiving 30 mg of aspirin a day and a 15.2% frequency in patients receiving 283 mg of aspirin a day, a non-significant difference between these two doses. The Swedish aspirin low-dose trial showed an 18% reduction in stroke in patients taking 75 mg of aspirin daily compared with placebo. Helgeson and colleagues compared the effects of 325, 650, 975, and 1,300 mg of aspirin a day in stroke patients. Platelet aggregation studies were performed to determine the effects of aspirin. 80% of patients had complete suppression of aggregation at a daily dose of 325 mg, an additional 5% responded at 650 mg per day, only 1% more responded at 975 mg per day, and there was no further response at 1,300 mg. As aspirin doses increase, so does the risk of gastrointestinal bleeding. The recommended dose for aspirin is 50 to 325 mg per day. The goal is to use the lowest effective aspirin dosage, thereby limiting the risk of gastrointestinal adverse effects. In the United States, a dose of 81 mg enteric-coated aspirin is usually started. Next we will focus on ticlopidine. Ticlopidine is an antiplatelet agent approved only for the prevention of transient ischemic attack and stroke for patients with a prior cerebral thrombotic event. By inhibiting ADP-induced platelet aggregation, its activity differs from that of aspirin. While effective in reducing risk of stroke, its use is limited by serious hematological and GI adverse effects. Regarding clopidogrel, clopidogrel is chemically related to ticlopidine and works by inhibiting platelet aggregation induced by ADP. A randomized, double-blind, international trial, clopidogrel versus aspirin in patients at risk of ischemic events, abbreviated as CAPRIE, compared clopidogrel 75 mg per day with aspirin 325 mg per day. Patients enrolled in the study had a history of atherosclerotic vascular disease manifested by recent ischemic stroke, myocardial infarction, or symptomatic peripheral vascular disease. Using intention to treat analysis, a 5.3% risk of an event in patients receiving clopidogrel and a 5.83% risk in patients receiving aspirin were observed. This represents a statistically significant relative risk reduction of 8.7%, favoring clopidogrel. On-treatment analysis showed a relative risk reduction of 9.4%, again in favor of clopidogrel. For patients whose primary condition for entry into CAPRIE was stroke, the relative risk reduction was 7.3%. However, this difference was not statistically significant. Patients receiving clopidogrel more frequently experienced rash and diarrhea compared with those receiving aspirin. Patients receiving aspirin were more frequently affected by upper gastrointestinal distress, intracranial hemorrhage, and gastrointestinal hemorrhage. Significant reductions in neutrophils occurred in 0.1% of patients on clopidogrel and in 0.17% of patients on aspirin. Some cases of thrombocytopenia purpura are reported in the literature. Clopidogrel is as effective and safe as aspirin. Clopidogrel is an alternative to aspirin in secondary prevention of stroke. Polymorphisms in the hepatic enzymes involved in the metabolism and activation of clopidogrel, CYP1A2, CYP3A4, CYP2C19, or within the platelet P2Y12 receptor may affect clopidogrel's antiplatelet therapy. Similarly, drug interactions affecting the CYP2C19P450 cytochrome can lead to decreased effectiveness of clopidogrel. Commonly prescribed proton pump inhibitors, such as omeprazole, have been suggested to decrease efficacy of clopidogrel. It is suggested to avoid the combination of omeprazole and clopidogrel until more solid evidence is available. We will now discuss aspirin co-formulated with dipyridamole. Dipyridamole inhibits phosphatase terrace and augments prostacylin-related platelet aggregation inhibition. 4 large randomized clinical trials have evaluated the secondary prevention effect of aspirin and dipyridamole combination among patients with stroke or transient ischemic attacks. 2 European studies have shown benefit with a combination of aspirin and dipyridamole. In the first study, a combination of aspirin 325 mg per day and immediate-release 75 mg dipyridamole 3 times a day was compared with placebo. Results from this study showed that the combination reduced the combined risk of stroke and death by 33% and the risk of stroke by 38%. The second European stroke prevention study enrolled patients who had experienced a previous stroke or transient ischemic attack and found that aspirin combined with dipyridamole was more effective than placebo, dipyridamole alone, and aspirin alone. A sustained-release formulation of dipyridamole was used for this study. A 37% relative risk reduction was found for the combination treatment, and a 23% relative risk reduction was found for aspirin alone. The dipyridamole dose for this study was 200 mg twice a day, and the aspirin dose was 25 transient ischemic attack twice daily. Absolute risk reduction was approximately 1.5% annually. Headache occurred more frequently in patients receiving dipyridamole alone or in combination with aspirin. Bleeding complications were less frequent in patients receiving dipyridamole compared with aspirin alone. As a result of these findings, a combination product of aspirin and dipyridamole is available. The combination of sustained-release dipyridamole and aspirin is an acceptable alternative for secondary prevention of stroke when initial secondary prevention has failed. In the 2006 open-label European, Australian Stroke Prevention in Reversible Ischemia trial, abbreviated as ESPRI, with a mean follow-up of 3.5 years, the combination aspirin, dipyridamole was associated with an absolute risk reduction of 1% per year for the composite primary outcome of vascular mortality, non-fatal stroke, non-fatal myocardial infarction, or major bleeding, that is 13% versus 16%. Bleeding rates were similar between the two groups. Combination aspirin, dipyridamole was discontinued secondary to headaches in 8.8% of patients. Of note, the aspirin dose ranged from 30 to 325 mg, and 83% of the patients took the extended-release formulation of dipyridamole. Clopidogrel was compared with the combination aspirin and extended-release dipyridamole in the non-inferiority prevention regimen for effectively avoiding second strokes trial. Among the patients with non-cardioembolic ischemic stroke who were followed for a mean of 2.5 years, there was no difference in stroke rates between the two intervention arms. The risk of gastrointestinal hemorrhage was higher in the aspirin plus extended dipyridamole group compared to clopidogrel, that is 4.1% versus 3.6%. Clopidogrel was better tolerated with less bleeding and less headaches than the combination. We will now progress to C-lostazole. C-lostazole is a vasodilator and antiplatelet agent. It has action on intracellular cyclic AMP and is a phosphodiesterase 3 inhibitor that is used mainly for intermittent claudication in patients with peripheral artery disease. In Asian studies, C-lostazole 100 mg twice daily was found to equally reduce risk of vascular events compared to aspirin in non-cardioembolic stroke. However, headache, diarrhea, palpitations, dizziness, and tachycardia were more frequent with C-lostazole than aspirin, leading to more discontinuation in therapy, that is 20% versus 12%. Given the ventricular tachycardia risk associated with C-lostazole, it is contraindicated in patients with heart failure. We will now talk about warfarin and oral anticoagulants. Large randomized trials have compared oral anticoagulants with aspirin in the secondary prevention of stroke and transient ischemic attack. In one study, aspirin 30 mg per day was compared with oral anticoagulants in doses adjusted to maintain an INR between 3 and 4.5. This study was terminated early when the mortality rate attributable to major bleeding events in the anticoagulant group was double the rate in the aspirin group. In this study, there was no difference between anticoagulants and aspirin in the frequency of stroke. A second study compared warfarin, dosed to maintain the INR between 1.4 and 2.8, and aspirin 325 mg per day. Results from this study did not demonstrate a significant difference between aspirin and warfarin with regard to the prevention of stroke or major hemorrhagic events. However, minor hemorrhages were significantly more frequent among patients receiving warfarin. A third study was terminated early because of safety concerns in the warfarin arm of the study. The target INR for this study was 2 to 3 in the warfarin arm compared with aspirin. The study was stopped owing to significantly higher rates of adverse events in individuals receiving warfarin and no difference in the risk of stroke. Events including major hemorrhage, myocardial infarction, or sudden death, and overall death were increased in those receiving warfarin. Warfarin is not generally recommended for secondary prevention of non-cardioembolic stroke. In secondary prevention of cardioembolic stroke originating from atrial fibrillation, warfarin or the newer oral anticoagulants are preferred first-line therapy. We will now discuss aspirin combined with clopidogrel. A major study has compared clopidogrel 75 mg per day with the combination of clopidogrel 75 mg per day and aspirin 75 mg per day. There was no difference in the risk of recurrent stroke or other cardiovascular outcomes between the groups, but the combination therapy group had a significant increase in life-threatening bleeding. Some individuals may be resistant to aspirin's effects on platelets. Although poorly understood and studied, aspirin resistance may be related to the presence of extra platelet sources of thromboxane A2 and an interaction with over-the-counter nonsteroidal anti-inflammatory drugs or high levels of circulating 11-dehydrothromboxane B2. Cyclooxygenase 2 expression is induced during human megakaryopoiesis and characterizes newly formed platelets. There are no data to suggest that increasing the aspirin dose will overcome possible resistance to the antiplatelet effects of aspirin, but it is clear that an increased dose of aspirin increases the risk of major bleeding. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 489.